Wahid, can you hear us? Wahid, can you hear us?
Dr. Masood, can you hear us?
He's muted right now.
Salam and greetings.
Welcome.
I hear you clear.
Can you hear me, Dr. Majru?
Hopefully, yes. Thank you.
Very good. All right, well, we're going to begin, everybody. Delighted to have this panel this afternoon. The last couple stages of our 5th International Clinical Engineering and Health Technology Management Congress. We've started Friday, as you all know, and we've had a preparation day that day, looking into the future, as well as 2 days of Congress where we had over 200 presentations, and today's the 4th day here in the afternoon, and we have this hour-and-a-half panel, and we're privileged to have some people in the panel that you'll learn more about here very quickly. And the topic is, as a Minister of Health of a LMIC particularly, low middle income country, what are the challenges around implementing health technologies, and particularly digital technologies, and a lot more than that, but that sets the tone a little bit. And I'm going to turn it over to the moderator, Dr. Manish Kohli, and he will talk about himself, but I'll tell you quickly, we have Dr. Vijay Agarwal here, Dr. Kohli, and online, Dr. Wahid Majru, who lives in Geneva, Switzerland, and was the former Minister of Health for several years of Afghanistan. So, Manish. And Manish will ask each of these folks to tell a little bit more about themselves, of course. But you start.
Well, good afternoon, everyone, and thank you, Tom, and hope that all of you had a very productive Congress. We are looking forward to an interactive dialogue. This is a fireside chat. We will be asking questions of each other, reflecting on some of the opportunities and challenges we see, especially as it has to do with medical technologies in healthcare. And then we welcome questions and audience participation, because this is really about all of us moving together to make healthcare better for each and every citizen. My name is Dr. Manish Kohli. I am a primary care physician. My career has led me through several amazing initiatives around digital health. I have served as CMIO for Cleveland Clinic in Abu Dhabi, Johns Hopkins, and with Partners Harvard. I was also the past chairman of Board of HIMSS, which is the largest health IT membership-based organization globally, representing 130,000 members. I currently am the founder and lead the Pull Alliance for Digital Health and Equity, and our mission is to empower and enable frontline organizations that are serving patients worldwide and empowering them with digital transformation. So bringing together the elements of workforce, clinical programs, and technology and funding to really make some change happen that can transform lives. So enough about me. I'm going to ask Dr. Vijay Agarwal to introduce himself.
Thank you, Manish, and thank you, Tom, for giving me this opportunity to share the stage with you stalwarts like you. So I'm Dr. Vijay Agarwal, and I am a pediatrician by background. Like Manish, I think in my life I have gone through many, many roads, including being a practicing pediatrician to going on to a social cause like introducing the pulse polio strategy to the country and to bring about polio eradication with the help of our health minister at that time, Dr. Harshvardhan. After that, I was inducted into the Max group and was responsible for setting the Max group of hospitals, so went into administration. And now for the last 7 years, I have joined this organization called CAHO, which is the Consortium of Accredited Healthcare Organizations, and that is to promote patient safety and quality in the country. So to us, medical errors are a huge problem, and one can try to understand the implication or I would say the magnitude of it, that in a country like United States, medical errors continue to be the third leading cause of death preventable medical errors. So one can imagine what must be happening in a country like India. So we don't have data, so people remain oblivious and are not that unhappy like you are in United States. My job is to make them unhappy and to start thinking about it and start working to reduce medical errors. So,
Thank you.
over to you.
Yeah. Thank you, Dr. Agarwal, and welcome officially. Dr. Majru, we would like you to introduce yourself. You are present with us from Geneva. I don't see you on the screen. Is he there? Oh.
I'm here. I hope you see. Do you see it now or not?
Yes, we can hear
Do
you.
you have that? But you don't have me on screen. My camera is on, and I see you all. I see myself, hopefully, as well.
Go ahead and introduce yourself, Dr. Majru, if you would.
Thank you very much. Again, good afternoon for you all. It is a pleasure to be among you, and I'm really sorry for missing the opportunity to meet you in person and enjoy the conference. This is where the inequity starts in the world of today. Visa issues and travel issues has become another hurdle, unfortunately. As kindly introduced by Tom, I come from Afghanistan. In my career, I've served at different levels with the national, international, private, and public sectors. My recent responsibility in Afghanistan was leading the health sector during the pandemic, as well as the conflict emergency. And I had the pride to be the last and the only senior official to stay in country post August 15th. And I had the pleasure of serving my nation for another two and a half months after the fall of the government. But the situation shaped in a way that I had to get out of the country. Currently, I'm in Switzerland, leading a newly established center called the Afghanistan Center for Health and Policy, Health and Security Peace Studies, through which we have collaboration with Tom and other colleagues. In regards to the topic of the discussion today, I was talking with Tom yesterday that interestingly it coincides with the ambition we had for the Afghan health sector from two perspectives. First, we wanted to bring a new example that a resilient health system can focus on development in the midst of crisis. So we came up with a comprehensive reform agenda, which a big part of that was digitalization of the Afghan health sector, which I will be happy to elaborate on that later on during the discussion. Thank you.
Well, I didn't hear Dr. Majru, and even though he's told me before his medical specialty, but as a former Kaiser Permanente person, I love primary care doctors. Pediatricians, internists, yes.
Yes. Yeah. Well, it's primary care is really where I think a lot of work needs to take place. But let's just frame what is it that we are trying to achieve. I can tell you from example in the US, we have invested or spent, I should say, a lot of money in digital health. But when we look at outcomes, we really have not made a significant change. When you look at quality and safety, when we look at cost of care, when we look at access of care, and when we look at workforce, how are we actually leveraging the workforce and how are we actually retaining the workforce? Healthcare accounts for 10% of the global GDP spend, 30% of it is wasted in the sense that it adds no value to the outcomes that we related. So I would say that this is the North Star that we're trying to achieve. Safe, effective, efficient, timely care that's cost effective. Technology becomes a really compelling and powerful tool. And what I want to do is really ask Dr. Agarwal and Dr. Majuri from their vantage points and leading transformations at the health systems level, at the government level, where do they see the biggest opportunities and biggest challenges where we as a community can come together? So Dr. Agarwal, I'd like you to kind of comment on exactly your perspective on leading changes and being a champion for quality and safety in India. What are some of the things that you see are going to be extremely ripe opportunities to invest in?
Yeah, so one thing for sure that technology is changing the face of almost everything that what we are doing in life. I think this smartphone has killed, I do not know how many industries, right from telephones to newspapers to anything. And therefore, and almost the fourth industrial revolution was announced almost many years back at Davos, and where that was announced that this fourth industrial revolution, which is the merger of the technology with the, kind of the biological parameters along with technology, sensors, 3D printing, artificial intelligence, all those things are going to impact the healthcare maximum, and the healthcare people are the least prepared for it. That's the kind of reality. However, I think pandemic, this COVID, has brought about, I think, a very major change in the mindset and the realities. So for example, in our country, telemedicine was almost illegal before the pandemic. There have been court judgments where telemedicine was really not accepted. There were some medical councils which had opined against it. So I think the first major change came about that. So digital health, as we have all been now talking about, that is going to be the one factor which is going to change. Now digital health is creeping into our functioning. For example, today WhatsApp is being used right and left for transmitting the X-rays, the ECGs, and everything for consultation. But what is needed is you need a much more refined structure if we want to make an impact in the traditional way of doing things. So healthcare itself is a very fragmented space. It's a very fragmented ecosystem. And unfortunately, the innovators or the digital health propagators, even the other technology, are also equally fragmented. And we need to kind of, I think at a very high level, we need to provide a direction. Direction to at least identify problems. What problem is going to be solved by technology which can make an impact in the delivery of healthcare? So for example, I'll say that recently we had articulated that as a problem, and that for example the nurses, they take the vitals of the patients every 4 hours. While the patient is in the ICU, there is a constant monitoring happening. He is a much more safe environment. Moment he is outside the ICU, the nurses are taking the vitals every 4 hours or even sometimes after 6 hours. And at times, because of the lot of work, it may not be even taken as meticulously or as honestly as one would like it to be. And there are examples where the patient will have a problem in between those measurement period and gets into a problem. So a need for automatic vital monitoring of the patient constantly was felt. And recently, for example, some people have come out, and now somebody has come out with a contactless monitoring of the vitals, including the pulse, respiration, blood pressure. And presently, for example, some hospitals, about 300 hospitals have started to use, and some hospitals are showing that the incidence of code blue means sudden cardiac arrest that we would get has reduced by 80 to 100%. So we need to further validate, we need to further encourage other players, because just one person or even two or three cannot be enough to provide this kind of a thing for the entire nation. So we can identify the success stories, successful case scenarios, and see that how do we scale it up. For example, I'll say almost 10 years back in one of our, 8 years back in one of our conferences, Amrita Institute presented a very nice case where a complex congenital heart, which was thought to be inoperable, but moment they made a 3D printed heart model of that patient, the surgeon realized, yes, he can operate. And he was very successfully operated. I'm sure that all complex pediatric congenital hearts can be subjected to a 3D heart model, but that has to become like a standardized practice, has to be scaled up. It should not remain merely at the whims of an individual doctor who may be more progressive and he thought about it, he's doing it. That institution may be doing it, but 50 other institutions are still probably not doing the best for that particular. So like this, I'm saying that one has to see where the disruptive solutions have come about and the need for scaling it up if we want to really make an impact in delivering healthcare.
Thank you, Dr. Agarwal. I want to come to Dr. Majuri, but I want to welcome a man who needs no introduction, Dr. Jitendra Sharma, who has been a wonderful host for the last 3 days. So let's give him a round of applause. Welcome. Dr. Sharma, we are simply trying to see how we can make healthcare better. I'm going to come back to you because you've been pushing the boundaries of innovation in India. But before I do so, I want to turn to Dr. Majuri. One other thing that you mentioned, and this is something that we as frontline practitioners have experienced, is regulations often lag behind what's needed. COVID was a prime example where there was a reactionary response where everything was possible. And in that we learned, wow, the technology existed for a long time. We could have done this a long time ago. How do we create better partnership with the government? How do we actually create more proactive policies that allow innovation and new models of care to come to bear? So we as healthcare practitioners can really push the boundaries in improving access and improving safety.
Thank you for the question. I believe, based on our experience in a country where conflict, violence, and lack of economic stability had been an issue, tells that issues in the development process like digitalization or use of technology is something which lies in the middle of the spectrum. And as rightly explained by the panelists, there are issues, there are steps, there are capacities that should and could be developed prior to that, and regulation and regulatory capacity in the country is a part of that. And besides that, our experience tells that lack of infrastructure, lack of culture, organizational and social culture toward what technology means, how it contributes, and how it brings in efficiency. And on the other side of the spectrum is the maintenance issue. So this private sector and the public sector has their accounts and a cost-effective analysis and see that whether it is a sustainable, efficient, and cost-wise worthy investment or not. So with that holistic look at technology and how digitalization of health sector can, at the end of the day, not only benefit the doctor, but the patient and the children in rural areas and urban areas, we have to relook at how we, at the decision-making stages, as well as the private sector where the technology is modified and defined, relook and revisit our strategies, because the experience in Afghanistan, and I'm sure that it's not unique and could be tested and heard from other contexts as well, is that it is not only a solution, but at some points it has become a fashion for policymakers or for leaders under the name of change or reform. But the in-points results shows that sustainability, lack of maintenance, lack of infrastructure, and human capital, not only to run what is existing, but to ensure they can develop and build up on that. Because one of the good or bad aspects of technology is that if you do not walk with the same path as technology walks, then you have just wasted the time, you have just wasted the resources, you don't have the version which adapts to the needs of today. So in that process, regulatory aspect in infrastructure is the most important and significant knobs, what I call it, in ensuring that a digitalized health system can deliver not only today, but beyond today, and can prove for the competitor ideas that it is more efficient, it is more effective, and it's more helpful for the patient and the physician. So with that lens in mind, given that there is not only an equity of access to technology, but an inequity to access to information about technology, causes countries like Afghanistan and others not to have the required capacity to develop regulatory systems, tools, and institutions to ensure that it eases the process, it facilitates the process of entry of technology, it does not block it, because there has been examples that bureaucrats who is not familiar, who is not used to it, and who are doomed into conspiracy theory, they resist. That's first. Secondly, they can ensure that several issues linked to technology, given it be the issue of privacy of patients, management of data, because using technology is the starting point. So what is next? For today and tomorrow? Data analysis, especially when it comes to big data, data management, data storage, data maintenance, has been another challenge in LMICs and fragile context. Security of data, security and safety and privacy of data has been another issue. Corruption, unfortunately, affects the regulatory process, which in short term, specific entities, specific sectors, specific institutions will benefit, but in the longer term, it creates a negative example which blocks the integration of technology within the system. So if there is not a holistic approach toward digitalization of the health sector, and if it is not looked in the context of larger institution called the state, because it is not only the health sector, our experience was similar. We realized that the point that we were running faster than others, which were creating a lot of challenges technically. So we were not able to connect with other ministries, with other stakeholders and institutions to make sure that we feed in data and we receive the feedback as required. On the other side, politically, it creates a very negative competition. And when you look at the society, you have to make sure that they realize the purpose of what you're doing. So you have to make sure that you do not only create the rules and regulations, but you're able to connect it with others. It looks like you have a good adapter for your laptop, the best run, but does it connect to the socket, the panel that you have? And on the other way, if you're able to communicate it at different levels to the policymakers, to the funders, and more specifically to patients, because they don't welcome it at every stage. And there are levels that you need to make sure that you make it as a facilitator, not to improve access. I hope I will have time to elaborate on that aspect of the benefits of technology as well. Because when it comes to polio, which our colleague pointed out that topic at some points, we had instances where I think examples that it had helped, technology had helped us, mobile platforms had helped us improve access not only to deliver the vaccine, but to get data as well. But there are several instances that use of technology caused 3.5 years of ban on how to have vaccination by Taliban, and 3.6 million children were deprived because they were thinking that our technology were transferring their GPS and other data from their localities. So it is a very, very significant and important tool to ensure patients receive a better health care, access is improved, equity is there, and efficiency is there. But at the same time, it looks like a double-sided knife. So we have to make sure that we consider both aspects of the topic. Thank you.
Thank you. That was a very, very profound and insightful explanation. Tom and Dr. Agarwal, you both have been part of complex change in complex health systems. And during the time of pandemic, Tom, you were leading significant efforts on education and advancing clinical engineering and deploying needed technology and help in the front lines. And Dr. Agarwal, you as the president of CAHO, you were on the ground in India, working with health systems that were struggling to cope with the patient demand and supply chain issues. Want the two of you to reflect on your experiences in the times of crisis, how you were able to drive change and what lessons we can learn and work with the policymakers to drive a more responsive regulatory framework.
Come on, Manish, you know I'm not that good. So I can't answer all of that, but I will tell a story, and it involves a pediatrician who wanted to improve access to his practice of 10 providers. It involves my colleague Mario Castañedo that we honored this week here at AMTZ, the teleradiology center named for him, and many of you attended the ceremony a couple days ago, and a hospital administrator friend. And so quickly the story was that this pediatrician, and I could name the country, but I don't want to get sidetracked with that. Anyway, the pediatrician said to Mario and I on a visit to his location, and by the way, I'm going to give away the location because he had 150,000 people within a half mile of his practice. So, there's this big country and then there's this other big country, but I won't name it. Anyway, and he wanted to, how could he change his facility and his practice that had been going on for 25 years? And I'm going to get to digitization very quick. How could he improve access? And we came back to him several months later with a way to triple access for this pediatrician and his 10 providers in the existing footprint that they were already in. Now, it was going to take some change to that, I think, 3 or 4 story building. But that's what he wanted. He had 150,000 people, and with many children, very close, and so how could he improve access? And so my friends Ricardo and Elliot will love this answer, and it does reflect my experience with Kaiser Permanente. So imagine, the interaction before the visit into this primary care setting in this clinic through social media. Our website, for me it's kaiserpermanente.org, kp.org, 14 million person healthcare delivery organization in the United States with several locations. So you start the interaction with the patient through the website or through social media before the visit. When you come, and I'll add in a little cultural flavor here, you come with your family. The child doesn't come by themselves, right? So they come with their family and they enter the building and there's a kiosk. This is what we envisioned for them. That was, secure enough, or they could have a discussion with the kiosk, so to speak, without other people hearing them and so forth. So the family is there at the kiosk. They were anticipated, of course, through the website and the social media visit or interaction before the visit. They're there for the child to be seen. As they log in the kiosk, they see the child's entire medical record. And they know what has happened to the child before, what kind of interventions have been in their health before, whether they've had the right vaccinations, what their primary diagnosis has been for their previous interactions with the primary care healthcare system, and so forth. And so while they're there for maybe asthma and a checking out of their childhood asthma, you know, if they need shots, if they need other vaccinations, that's seen. If they need to be treated for other things related, they can be seen for those. But anyway, so their history is known, and they enter into the exam room for treatment for the reason they came, but they're getting these other services related that are needed for their past history. Now, what care they get there, Dr. Majru, when they go in the room, and Dr. Agarwal, I think you both talked about, is really clinical practice, evidence-based clinical practice guideline driven. Now, we all know that's probably 95% of what should be done for that child right at that moment. The doctor's still going to see things that are maybe outside the bounds of those evidence-based guidelines because every person is different. But that knowledge of the evidence-based guidelines and the resources associated with delivering that treatment, the meds, the devices to make the right measurements, all of that are in the room because they were planned ahead of time. And so the child receives the treatment for which they came in, the purpose of the visit, but they also, as you've already heard, get this other treatment. And then, you know, get the appropriate medical education, whatever, and then they depart. And then there's follow-up, once again, through social media. Okay, now I'm going to give it away. It's WeChat in their country. But, and we know these interactions with the patient need to be secure. And, and WeChat's not secure. Sorry about that. But so you can imagine, though, that through a website or through social media, there's follow-up with that visit. And we calculated, Mario Castaneda, myself, working with our physician colleagues and thinking about it, and with this hospital administrator who thinks about all the resources, that access could be tripled. So that's my answer. And so how does that help during COVID? Well, you can imagine you can set up systems to, you know, ahead of time to diagnose, you know, pulse oximetry and the like and so on. So I'll stop.
No, thank you, Tom. And you know, I think one of the things that's clear, the patient base now is much more technologically savvy. And like it or not, WhatsApp and social media are becoming important channels of healthcare delivery and healthcare consumption. And we see that in India, we see that in the other big country that you mentioned. So Dr. Agarwal, from your vantage point, let's hear some thoughts.
So, to my mind, number one, I find that the major challenges of healthcare are the accessibility and affordability. These are the two major things, almost world over, but definitely in the low and the middle income countries. And therefore, the stories like what Tom has just told, there are, of course, I can tell you a number of such anecdotal individual efforts by the people who have made definitely the healthcare delivery much more efficient, much more practical, and even affordable. But what I'm trying to say is that we need to scale up our efforts as by reaching out to the policy makers. So for example, one of the problems of healthcare being affordable in a country like especially low middle income countries are the medical equipments, which we are importing right, left and center from the Western world. We pay duty on it and they're extremely expensive. Now with the kind of facility that we saw today in Amtz, where there is a huge amount of quality control, the people at the end users that we represent, I can tell you, their faith in the made in India products is the lack of their confidence in the quality of that product. So somewhere along the line, we have to take that quality control and give that confidence to the people that, it is going through such rigorous kind of a quality control. But unfortunately, there may be 10 of such bodies which are trying to give the quality control. Now in US, you have this ECRI, the ECRI, which is a very reputed kind of a body, and it does and the whole thing is to give the certification to the medical equipments, and it is related to the patient safety. The whole genesis of ECRI started because a particular defibrillator did not work in a child. And that's where the doctor had created that whole hue and cry, and the medical equipment became a part of the FDA approval process. We need to have something similar and a more of a unified body which is trying to give a quality control to make the medical equipments and then making it kind of affordable. Similarly, accessibility, the telemedicine, and all the paraphernalia which are associated with it need to be kind of brought on a much more, I would say, structured level. Third thing is that the healthcare delivery is almost like an ocean. So it's not that simple, because there is going to be something in pediatrics, 101 things in orthopedics, in cardiology, and so on and so forth. So you can keep on, I think it's like, unfortunately, sometimes I feel healthcare is like blind people describing the elephant. So you don't even know what exactly are the dimensions of the healthcare unless you have tried to see it from all angles, and then you see what the problems are. So I think the solution will lie in handling this elephant bit by bit, but on a much more structured and a very high level. Individual, I would say, enterprise is of course the way where things have been moving upwards, and will be, moment somebody comes with an extremely innovative and disruptive solution, it will overtake. I'm sure, like, I don't know what somebody would have imagined that what will WhatsApp do. WhatsApp has changed the way I think people live their lives, both in good and bad way. But the issue is this, that as a platform, as a product, it's highly disruptive. Same way, I think we need to look at different solutions, different platforms, which can make the healthcare affordable, accessible, efficient, and effective.
So Dr. Kohli, I'm going to jump in and ask you this question. As a health IT leader, one of the global health IT leaders, what stories can you tell us where quality, safety, efficiency all improved as a result of digital tools being used?
Sure. So it's really not about technology.
And affordability.
And affordability. So caveat, every system is perfectly designed to achieve the results it does. I think we can all agree that we have a crisis in healthcare. We have to treat it as such, because the data on safety and quality and patient harm is too appalling. We simply cannot leave 3 billion people without access to healthcare despite spending 10% of our earnings. It's just not sustainable. And guess what? Magically, there's not going to be an increase in the amount of money that's available. We have to figure out how do we squeeze everything to make healthcare more efficient so that more people have access and access to quality care. And quality becomes important because quality in every industry has been shown to save costs. And if people have access to care at the right time, we can actually prevent late-stage complications. But we also need to have the right payer models. If we continue to incentivize expensive procedures, we are going to have facilities that are going to deliver expensive procedures and doctors and nurses who are going to train in those areas. As simple as that. Primary care, community-based care really has to be the center stage, because that's really where we can achieve the most cost efficiencies. I'll give you an example. from a hospital setting where the combination of people, processes, technology, and data allowed us to demonstrate a high level of quality. So I had the opportunity and a privilege to help build a hospital in the likeness of Cleveland Clinic in the Middle East. And part of our mandate was not to just build a hospital with a marquee, but really to deliver on the quality. How do you begin to do that? Because it's a big elephant, right? And you're coming in a brand new regulatory landscape.
There's a lot of big elephants around here.
Yeah, a lot of big elephants around here, yes. So we said, what are the areas that are important, and how do you actually begin to align our people, our processes, and our technology to deliver that outcome? So one of the hardest things in healthcare, and Dr. Agarwal will agree, is getting doctors to agree on what quality is, right? So I think we have some work to do as a community where we say, you know what, for stroke, this is what we consider to be a national standard. And we are going to hold everybody accountable to that. So Cleveland Clinic has invested time and resources in building care pathways, which are standardized care around 80 conditions: back pain, stroke, acute MI, and so forth. We chose stroke because that was an important disease state in the Middle East that needed to be addressed. And what we were able to do is take the best practices from the US, regionalize them, and then build them onto the digital health platform. So it's not simply you are deploying an EMR and saying use it. We built in order sets and best practice alert and communication tools so that when a stroke patient did come to the ER, a lot of things were triggered because a lot of multiple activities need to happen simultaneously so that the stroke patient gets the right care, the right diagnostics, the right therapeutics, and the right follow-up care so that you preserve brain tissue because that's what leads to best outcomes. And we were named the stroke center for the Emirate of Abu Dhabi within a year of opening. A brand new hospital that is actually achieving that. And by the way, the entire workforce was new. People had not even worked together. So what technology did for us was not only allow us to build a standardized pathway on top of that, but allow the team to work as an orchestra. And healthcare is a team sport. So when we look at how we bring quality to bear at an organizational level, there is just no other way. Where we really have to say that we need clinical engineers, we need pharmacists, we need nurses, we need doctors, we need administrators acting in concert to solve some particular problems. And how do you begin about that, right? You look at things that are high risk, high cost. You know, that is typically the model that many leading health institutions use because we cannot boil the ocean. But the beauty of this, and I can give you many examples, is that you do one thing correctly and show success, there is this effect, halo effect, that you see improvement in other areas. Because there's nothing more infectious than success. And people are just looking for leadership and a way on how to do it. And I think technology is there that supports that. I'll give an example out of India as well, where during the pandemic, one of the insurance companies in India invested some money as part of their CSR to make 3 primary health centers smart health centers. Basic technology. This is not expensive technology. Point of care diagnostics, telehealth, and they were able to provide access to care to 20,000 patient visits. 15,000, and some of you have heard me say this, 15,000 primary care, 5,000 specialty visits, 2,000 hypertensives who did not know they had hypertension were diagnosed and treated. Think about the public health impact of that. Think about the quality of life impact. 1,000 diabetics, right? So a small investment can go a long way, but it really is what you said, and I really love what you have consistently said, technology with a purpose. We need to figure out what is it that we're trying to achieve, where are we trying to point the needle and come together as an ecosystem. And this is where we need the policymakers and the payers to say, you know, we are going to reward certain things that have a tangible, long-term impact on the population.
I know Wahid had some thoughts
Yeah.
as well to share. Is it-
Thanks, Tom. Is there a specific question, or I can elaborate on what was discussed by colleagues at the panel?
Well, I know you talking about team culture and maybe clinical workflows were kind of worked out from the beginning, and there was agreement from all kinds of providers and those that supported those providers. I don't know if you have thoughts about how you experienced that in
Sure.
Afghanistan.
Sure, sure. As I said, I'm a man of both big picture and detail. So I have to make sure that I see the big picture, where the health sector fits in, and then within the health sector technology fits in, and how it connects to the society, to our domestic and external stakeholders. And when it comes to within the health sector, to which building block the health sector, the health technology will further contribute. Our short experience in Afghanistan taught us very good lessons. The first point is that it starts from the mindset. So if there is the mindset and leadership is ready to bring in technology and is positive toward it. If that is not available, then we have witnessed during the last 2 decades that there are many opportunities were wasted. In technology, as explained earlier, it is not a one-shot game. More than equipments, more than hardware, it requires the culture, it requires the systems, the institutions, the management tools. And that could not be downloaded and installed. The way our international partners acted during the first decade of their contribution in Afghanistan, that they thought that everything could be downloaded from the West and then installed in Afghanistan. So what they did practically, they brought in a lot of medical technologies, high tech, but as I said, on the ground there was no human capital, no institutional capacity, no management and maintenance system, and what we ended up was stocks filled out with big machines, equipments, with no use. So my approach within the reform agenda that we had shaped, and the health sector digitalization was a significant part of that, was to make sure that we look at digitalization as a process, not a project. That's first. It covers the continuum of care, and the most important knobs out there are two: the patient, who is the recipient, and the physician and healthcare staff members, whom are the ultimate delivery points for the health service delivery. And in between, the chance that we had at that point was the policymaker or the political decision makers were mentally prepared for it. But there was a challenge that our friends Manish and Dr. Agarwal also pointed out, was we have to make sure that the technology we bring in fits into the context. So there was a struggle. I was looking at Iran and in India as two models, two examples that could be replicated to Afghanistan for different purposes, cost-wise, cultural-wise, ease of access, and several others. But there were colleagues in our system that they were, for example, insisting on once on Siemens, once on IBM or some big names, but not looking whether they had a successful experience in health digital technology as well, because technology is a big mouth-filling name, but health technology is a specific area which has its own stars around the world. So with that perspective in mind, in a country like Afghanistan, now Palestine, Syria, Libya, if used and if looked and if managed well, technology does not only improve efficiency, but it is sometimes at some points it becomes the only tool for people to access healthcare. During the pandemic and during the conflict emergency, as well as the polio eradication efforts, I believe that the experience that Afghanistan presented in utilizing technology effectively and efficiently could be replicated in other parts of the world. And beyond that, I don't look at technology, as I said, what we did yesterday, but I found it is utilization at every step of your engagement with people until you remain connected to the health sector. Could it be a manager, a physician, a trainer? Today, technology is the only source where you can help Afghan people, 35 million people, have access to quality healthcare services for several reasons. India, for political issues, do not issue visas. India has been our second home for healthcare and access to healthcare services for decades. And there were reports that $300 to $500 million were spent by Afghans seeking healthcare in India, and there is that's not available anymore. In country, unfortunately, the brain drain has caused the scheme of the health sector, human capital, to leave the country. When it comes to gender issue, you know that there was a huge ban on women education in Afghanistan. So there is, besides all the negative aspects that we get concerned about use of technology at some point, especially when there is no strategy for knowledge transfer and technology transfer in mind, and there is no longer perspective on how domestic capacity could be developed, especially in LMICs, but there are hopes, there are opportunities as well. In a smaller scale, what I and my group have been using is to use technology as a means for telemedicine, not only connect the Afghan diaspora with the population, but still I have many friends in India that they help their infertile patients in Afghanistan, and I use this platform to thank them for the connection and for the assistance. We here at the Afghanistan Center for Health and Peace Studies try to join forces, and we have already delivered a huge amount of trainings for Afghan female doctors to make sure that their knowledge stays up to date. The next step we're envisioning is to ensure to design a package for midwives, because when there is no OBG physicians, so we have to focus on the skill shift, that some tasks could be taken on by midwives. I'm thankful of IFMB for the MOUs that we are working on. We're also using technology to help those involved in health technology in Afghanistan with medical equipments, which, as I said, in the beginning, there was a huge interest to bring in medical technologies, but given that there was not human capital for the maintenance and management, then even if the private sector became hesitant of bringing in new technologies. So that contributed to the expansion of health tourism. Now with IFMB and GCA, we're trying to design online trainings for Afghan medical by medical technicians and engineers. So, as I said in the beginning, there are several issues that could be discussed along the spectrum of using of health technology or technology in the health sector. There are opportunities that, if not utilized well, can not only harm financially, but the patient safety and several other aspects as well. But that's not the whole story. In my case, in Afghanistan, I see a technology at some points as one of the only solutions available to help contribute during the whole spectrum of the healthcare. Could it be the monitoring and evaluation, which has been difficult, service delivery and access to healthcare, especially to those areas where people are deprived of, getting data, because if you look and go into the literature, one of the big issues in Afghanistan is that you don't have access to data to analyze and come up with a result on a specific topic. And that's not only a problem, because, as I say, any topic related to technology requires the mindset and culture as well. So we have to make sure that we help the professionals not only get used to collecting data, but using it and believing in it and improving the quality of it. And that's another opportunity. And when it comes to human capital, technology has become the only source for us now as Afghans to make sure that we create a platform or a channel through which we connect the diaspora and our international partners. And I use this platform to call on our colleagues, the audience of this program, IFMBA, GCA, and other networks to come in and help us in this endeavor to make sure that we can provide an opportunity for Afghan female healthcare workers to get access to good quality medical education. On the other side, to connect Afghan diaspora and our international partners to our patients whom are just badly in need of good service advices and at some points health services. So overall, my experience shows that there are threats and opportunities, but sticking to the threats will not create a solution. We have to make sure that we look at use of technology as a work in progress, in learning by doing things. We have to make sure that we contextualize it. We consider it as cost effectiveness analysis to ensure that we can convince policymakers, patients, and physicians and healthcare workers that it is a tool to make things better, not only a mean to sell expensive high-tech items that could be used only for a few days, like mobile iPhones, that we have it, but there are several instances in underdeveloped countries that they use maybe 0.5% of the facilities it provide. And that has been a very common example in our context. I was and still I am the only Afghan physician who imported the best and the latest version of ultrasound GE machine to Afghanistan. My colleagues may be familiar with the good name Dr. Ashok Khurana, has been my close friend in Delhi. And that example showed me that there had been several clinics in Afghanistan that they had the best technology, but as I said, similar to iPhone, it is used for calling and taking photos, whilst in India, they use it for, as nicely Dr. Agarwal said, it has changed the way people live. So when we look at technology, we take people to invest it, we get people to invest in it, we have to make sure we equip them with the right means and skills to use the best out of it. Not only just make it a short-term success and then a negative lesson for the next phases. I thank you.
We want audience engagement, so we're going to ask the mic to be passed around. So people have questions. You know, this is, we'd love to sort of get questions from the audience as well.
And Manish, there's no way I could respond to the breadth of what the minister said.
I know.
But as people maybe are lining up and queuing up for the questions, he mentioned some work on MOU that's in process with the Global Clinical Engineering Alliance. Dr. David and I have been working with him and Uma Abdul. I don't know, Uma, if you're out in the crowd, but Uma's a clinical engineer whose family is from Afghanistan. She's in the Veterans Administration system in the U.S., a very accomplished clinical engineer, and she's got a heart for her country, not surprisingly. So one thing with Dr. Majroor that she's done is create a clinical engineering survey of her country, and he has the network to send it out to, and there's been over 100 responses, physicians, nurses, engineers in the country, and we're trying to shape some education around that in the country, but he's also talking about bringing the diaspora of Afghan brains that are around the world together in Zoom calls, whatever, networking, to look for innovative ways to deliver care to the country. I mean, telehealth comes to mind, particularly in the context of maternal child health, but many other areas where this could be done. But Elliot?
Yeah, my name's Elliot Sloan, and I've spent 20 years working with the international standards for interoperability for devices and for systems, and we're making good progress on the technical side. I don't think we're making much progress on the cultural side. There are a number of gaps there are a number of points of resistance that are very, very significant. I recall a very angry attack by a nurse about automating vital signs, and she insisted that automating vital signs is absolutely absurd. The nurse has to look at each and every vital sign measurement before it can be put into the system. Okay, you're kind of going back to stone tablets.
So a little bit of culture change might be needed.
It's a culture change, but it talks to, Dr. Coley said, trust. The example I give is airplane pilots would not fly in clouds if they didn't trust that the other airplanes were not heading towards them unseen. There's a trust that has to happen, and it's a cultural change, and we certainly, through the pandemic, have seen some of that. Now, we also have physicians who don't really want to have their findings visible to their colleagues because they're measured on their performance. So they either bury their findings in comments, or they have their own laptop or their own smartphone, and they keep their own records and sanitize what's put in the medical record. That's a cultural issue. And then you have hospitals that don't really want to share information, and you have government agencies that don't want to share information. The concept of a rising tide floats all boats is, in other words, things that improve, everyone benefits from. That's philosophically good, but if your boat is anchored on a short anchor, your boat's going to sink when the tide rises. There are just a lot of other cultural issues, and unintended consequences are part of what we're experiencing in the United States. We required that all electronic medical record systems have a patient portal so the patient can see their own data. What happened is that every practice created a different patient portal. So every patient sees different data, and they can't integrate their data. And the physician can't see the data from other practices or specialists. So we're making progress, and a comment was made earlier about regulations lag innovation. And I think here is a big opportunity to work together to change those practices, habits, to take advantage of the technologies. It's a long journey.
And we're counting on Dr. Sharma to do that, of course, for India.
Culture always eats strategy for lunch. But really, I think the key is bold leadership at the organizational level, at the policy level. Nothing else will move the dial. And I can give you one example from an institution I served at early in my career, where the organization leader said that we are going to undergo digital transformation. It is for patient safety. You have a choice. Are you going to be on the ship or off the ship? But if you decide to be on the ship, we are going to do A, B, C, and D to help you through the journey. And by the way, here are the carrots and the sticks. And I think those are really important. So one example was, let's look at the data that is going to be the most critical for patient safety. Medications come to mind, especially in the outpatient setting. If the medication list is current and complete and you have allergy data, you can actually address a lot of safety issues in outpatient setting. So we said, if you have 95% of your allergies, allergy data for 95% of your visits in the EMR by a certain date, part of your compensation, you will get a bonus as part of your compensation. However, if you fall below that, you are going to have a penalty. And that simple act, on the date the metric was we met, there was 82% compliance. And that curve went up and stabilized at 95%. And the other piece was put your mouth where your money is, but walk the shoes of your physician. So this physician leader, my boss, she was at that time in her 60s, maybe late 60s. And she said, I'm doing this. So if I can do this, you can do so. So really, I think at the ground level, you really need bold leadership and leaders who are willing to say, we're going to move in that direction.
Can give just one more comment that cultural change also requires a strategy. It is not going to happen on its own. You know, the innovation has happened. That's in fact an easier part. And the cultural change also requires a strategy. So for example, for the automation of the vital signs and all that, you have to expect that there is going to be resistance. And there are very valid arguments, let us say, put forward. So you have to get data. So for example, we were working to get data as to how much time a nurse is spending on taking vitals. Does it make economic sense to shift to the new thing? Secondly, data on patient safety. So, and third thing is that this data and everything should be multi-centric, should bring confidence in people in that data. It cannot be only vendor-produced data. That person is naturally ready. You see, a number of innovations are coming from the private sector and from very enterprising young people. The first thing is there is a mistrust between the thing which has been produced and the rest of the ecosystem. So we have to try to address, but once you address that, no, that this makes sense, the ecosystem has to support this person. And somewhere one has to forget, I mean, naturally somebody is going to make some profit, some credibility is going to come to that solution which is being adopted. So it is definitely complex, and I feel that the cultural change requires, again, a leadership, like what we said, a leadership thought process as to how do I convince the other people, including at the local level. Yes, the carrot and stick policy, it has worked.
And I would say the opportunity here is obvious. We need to invest in leadership training. We really need to inculcate this. A lead by example, but really begin to say, you know, we are going to call out this competency, and we are actually going to train future leaders in that. And I think at the ground level, this is the only thing that changes healthcare. You know, in addition to policy. So this is really where we started, right? If you have the right payer mechanism, if you get rewarded for doing the right things, you know, the ship will move in that direction. If you have the policy, you know, it will cause change. What I hear oftentimes in countries that are struggling with embarking on digital transformation is that there's no incentive for me to do this. Why would I spend money on technology and actually lose money? You know, or there is no regulation that requires me, so things remain status quo. And this is really where bringing in regulators, payers, health systems leaders, innovators in a forum like this is really what's needed. Because we can't do it alone. It's a big elephant, and to move it in a direction that's going to impact patient care, we need everybody working in concert. The other challenge that I see is medicine is moving fast, technology is moving fast. But the rate of bringing medical knowledge to the front lines lags. Technology moves, but regulations lag. We have to fix that, right? There needs to be an alignment there where we can actually make the right things happen, because if technology is leading healthcare, we have a problem. Technology cannot lead healthcare. Healthcare has to lead technology and innovation. We must, you know, be having that dialogue. Otherwise, you know, you see some of the challenges that have emerged in social media and other things that have caused, you know, societal challenges. Dr. Sharma is back here. He's been a pioneer and a leader and innovator in the medical devices space in India. I'd like to hear your thoughts on how you move towards better patient care, and how do you deal with some of the challenges that have been discussed on the panel?
Yeah, I'll be very brief. Thank you, and apologies that I have to go in and out many times. We also have two wonderful physicians from other part of country today, Dr. Naval and Dr. Rajat. If you can raise your hand. Dr. Naval is actually physician to the defense minister of the country. and also the Minister of Shipping and Ports. Dr. Rajat is actually one of the best cardiologists that we have in the central India, and he is also owner of a chain of hospitals. So welcome, friends, and I would also like somebody to pass on the mic to Dr. Rajat if you have few comments on the session which is going on before I speak, if that is okay.
And also, Dr. Majroo has some more comments
Yes.
at the appropriate time.
Yes.
I think, sir, the biggest challenge as hospital owners and as well as doctors is, our panel members have clearly mentioned, it's like optimizing the doctor to follow two things particularly. One of them is, clinical pathways, which, every doctor believes, we have legacy issues with a lot of doctors. Senior one thinks that he knows everything. And it is the clinical pathway that, Cleveland has done wonderfully, and I see a lot of these hospitals being, followed. And I am really not sure that, in anywhere in our country, and I've worked in multiple hospitals, every doctor has his own way, which he thinks is superior to his colleague or his junior or whosoever. The second part was very interesting, and, and with Dr. Sharma, as we've been having a talk on, hemodynamic measurements of patients in while the patients are in the ward, particularly in the night. There are so many MIs and in hospital deaths, which are I would say not carelessness of the nurses or the doctors, but it's the system, the challenges of the systems, which we've not been over years, not been able to change particularly. Let's say a nurse visits a patient at 3 a.m. and at 4 a.m. and her next visit was, let's say, scheduled at 6 a.m. but at 4 a.m. the patient has a massive MI, and really no one could, judge it because, we were only measuring basic things. I think these are the two important things that we must, and there are many more, but I think these are the two important things which I've taken it from the discussion. And let's hope leaders like you take it forward, and with Dr. Sharma's innovations, I think we would eventually reach where we want to. Thank you.
Thank you, Dr. Rajat. I just wanted these comments to actually be part of our thinking process. So thank you for allowing that.
Thank you.
Look, from my perspective, I would like all of you to take a couple of steps back, including the Honorable Minister. And by couple of steps back, I mean 2000 years back. If we were to be in 50 BC or 100 AD, and if I were to give Tom this mic, I would give it in exchange of a bottle he has, that he could give it to me. We have to meet each other's needs because there was no common modality for transaction, which we call money. Money got invented later on. Needs were being fulfilled even without money. And therefore, we must differentiate between what is our need and how do we want to transact that need. Most of the times we mix it up. The transaction modality becomes the need, and need starts to reflect transaction modality. If the need is patient care, digital health is a transaction modality. Who knows, 100 years from now, there would be something else. And we would be discussing for penetrating that to meet our needs. Needs are constant. Now, if you look at what Minister said from Afghanistan about maintenance of equipment, not just capital acquisition of equipment. When you look at challenge of EMR, digital health penetration, these are, we must categorize them as need or transaction modality. They are not the same. Eventually, we will lead to a point, what did Tom consider in 100 AD worth giving away if he were to get this mic, which is valuation of what serves our need. Now, if this valuation is very high, whether it is for medical equipment, digital health, server space, analytics, repair and maintenance, if the valuation is very high, sometimes they start compromising our needs. So a village in Bangladesh or India or Afghanistan may need an MRI, but an MRI is $1 million. Hence, we compromise on the need because the valuation of need is very high. And what we believe in at AMTZ is, can we break down that valuation to not compromise with the need? And I'll just give you 2 simple examples. We have rolled out a new program in which we supply medical equipment. Since we make all of it here, we supply medical equipment. And this is interesting because it actually proves that valuation can help us match demand-supply gap effectively. We have started supplying medical equipment from hospital bed to syringe pump, from volumetric pump to multi-parameter monitor, from ultrasound machine to ECG, electrode and everything. For, in India, 1,000 rupees per bed per day. And outside India, $25 per bed per day. And when we say supply, it means you give us an empty shell and we make a hospital out of it. We repair it whenever there is need with a downtime less than 2%. We maintain it, we keep it calibrated, we keep it quality controlled, and we do it for 7 years. All like an electricity meter, cost per bed per day. The need does not get fulfilled, and the need gets fulfilled without getting compromised, and we call this Uberization of technology. Instead of asking you to buy a car, instead of asking Afghanistan to buy an ultrasound machine and force them to battle the maintenance problem as much as everything else, can we actually tell them we can supply you not just an ultrasound machine, but a whole clinic, a whole hospital, a whole ward at a cost per bed per day, which includes maintenance, which includes training. On the digital health, since the cost of digital health is software, hardware, fiber optics, internet security, cyber security, again, a mix of downtime and efficiency, human resources, bandwidth, can all of it be given to a hospital at, say, $5 per bed per day? How long will we say hospitals, this is nice and this is better to have and this is must have, without addressing their core problem, which is at what cost do you want to give it? And I think whatever we may be influencing our public sector and private sector healthcare markets to be, as long as we meet demand-supply gap at right valuation, irrespective of which century we are in, what modality of transaction we are talking about, given at what point of time in history and evolution we are, as long as we match demand-supply gap with the right value of valuation to the end client, I think we will be marching forward.
It's great. What's great about your vision of the future is it's actually today and you're doing it. And we thank you for that. And we need to learn from that. We got about 10 minutes left. Maybe some closing comments?
Sure. Dr. Agarwal, would you like to say some final thoughts?
No, I think the visit to AMTZ had been an eye-opening experience. And again, what I'm saying is that these kinds of facilities need to be kind of exposed to the wider medical fraternity. And these ideas, now, for example, basically the concept that Jitendra ji just talked about was the leasing of equipments at a particular price. It started some years back, went into disrepute because, again, you need to have somebody with a bandwidth to do this. And I'm very happy that somebody like AMTZ is coming out with such schemes. Even I would say that our Ayushman Bharat digital mission is a huge, I would say, step in bringing about the interoperability of the medical records and all that, because the basic infrastructure or the digital pathway has been created keeping that in mind. So that, I would say, step in India is a very progressive step and should go towards the interoperability. However, you need again many more players to work along with NHA and the Digital Health Mission to get the juice out of it. Otherwise, it's going to rot. That's my feeling.
Thank you, thank you. I want to turn to Dr. Majroo for his final thoughts.
Thank you for the great rich discussion. I really find it interesting, and I feel more sorry for missing this great conference. Anyways, on the last issue of trust and trust building and culture, I still want to reiterate that the health technology and then the health sector operates in a larger setting, which is the society and the government. So if we are determined to improve people's and physicians' trust and improve, just create the culture, the nurturing culture to better use technology, we have to make sure not only on the machines, on the hardware, and on good presentations that we prepare, but on the continuum, whether it is medical education, because if a physician is not trustworthy, the technology that you give, the best technology you give in his hand will not be trusted by the patient. Or the system which operates and delivers the service, if it is corrupt, then you cannot expect the patient to solely trust the service delivery because your technology is a good technology. So it is a holistic issue, which I believe technology can contribute to any steps of this process, given it be to addressing the corruption, efficiency, sustainability, access, availability, or affordability. What I would recommend is to continue examples of what we had today, to have more discussions, not only within the elites of technology community, but to engage society, which are the ultimate recipients of the service delivery. This is what we are doing in our center. In any discussion we have made, unfortunately, in the past, the medical field very special field where we only invite the experts, but we have changed our approach, and then in any discussion we have someone from the community who are the real recipients of the service delivery to get their perspectives as well. I thank you for inviting me in the great discussions we had. I will be looking forward to further engagement with ICEHTMC and GCA and other colleagues in the panel. I wish you all the best. Thank you.
Thank you, Dr. Majroo. I do want to call on our colleague from East Africa, Millicent, for a couple of comments. Millicent, do you have a microphone?
Yes, please. Thank you so much. Thank you so much for the good deliberations that have been taking place. And I would want to comment on two things. Number one is about the qualifying body of medical equipment. I know we have talked about FDA, we've talked about the ECRI, and there's also an ISO. My question is to Tom, probably if time allows. With the number
But go ahead.
With the number of MOUs that you are signing with different organizations, could you come up with something like a qualifying body that will be able to, accredit devices in Africa region? Because I know FDA is so US-based, ECRI, but we have nothing actually for Africa. If there is, then I'll be happy to know that.
And the short answer is, together with you and your colleagues, anything
Yes.
is possible.
Oh,
I
thank
mean,
you.
because Jitender's shown us that, but go ahead.
Yeah, so that's one. And then the next thing is to Dr. Sharma. Dr. Sharma, I'm so proud of the work that you've done. And we've actually gone through the tour of MTZ, and it's amazing. But one thing I normally think about is the end process. You've done so well. I'm looking at Africa again in my mind, and I'm thinking of the major problem we are having is disposal of these devices that you are making. There's quite a lot going on, and so many beautiful and nice devices are coming up. But then we get them without being advised, after all this, where do I take it when the end of time comes? So then we end up with a lot of junkyards in our hospitals, in our facilities, in our organizations, without knowing where to go. So, of course, I know probably you have an end plan, but I would just suggest that in all this that we are doing, whenever we are distributing the devices, can we make the end process, the disposal process, like the very first, that the customers are aware of, that at the end of this particular device, this is how you are supposed to dispose it of. Do we take it back to AMTZ? What do we do with the devices? Thank you so much. Over.
Thank you. Excellent questions. I have comments on all three, and then I pass it on to Tom. Yeah.
You can do anything, but we've got 3 minutes left.
Yes. Any agency which has to become a scheme owner of accreditation needs somebody to qualify them to be so. I cannot stand up and say, from tomorrow I will accredit you. Somebody must give me a power to do so. And that universal body is called International Accreditation Forum, where accreditators of all around the world actually meet, and one of our colleagues is today in Montreal actually participating in the executive body meeting of IAF. It's different from IMF of Mission Impossible of Tom Cruise. The IAF gives you the power. AMTZ is accredited by IAF. So the short answer is to create a regulatory framework for East Africa. AMTZ, which is IAF certified, can work with GCA, and we can create a qualifying accreditation system for devices. The second, which is your third question, but in answer it would be in point second, is how do we measure the end life? Some might not be junk, but moral hazards in the market may declare it as junk so that they sell new. They might not be junk, and they might be nomenclatured as junk in the hospital. So there is no program of residual shelf life evaluation for medical devices that we have in automobiles. We have a residual shelf life valuation center, we call it RSLV. We would be happy to see if a residual shelf life evaluation could be done again with GCA and our support in your context. And the third is waste disposal. Now if you look at medical devices, the waste disposal is primarily in three parts. The consumables, which are sent back to the resin polycarbonate factories where they are melted, new resins are made. That's recycling of plastics and anything which is made of polymers and materials. The electronics, which leads to electronic waste management because you get rare earth metals from the chips. We have a center coming up for e-waste here in AMTZ campus, but there are e-waste facilities all over. Some might be more expensive than others, but electronic waste must go to an e-waste facility once they are declared to be no more of substantial use. They actually have tremendous value because of rare elements in them. And the third is radiology waste, which must be discarded only by the Atomic Energy Agency of the region, which is again accredited by IEA, the International Atomic Energy Association, the IAEA.
So Jatender, I hear you saying there are solutions out there. And
so solutions are out there. We must converge with our collective powers to get answers to the last mile.
Sure.
And let me quickly say, CED, and I'm not picking on you, Millicent, is you and all of our international clinical engineering, biomedical engineering guests.
Yeah.
And GCA is you, it's all of us together. So some other group in some back room are not making these decisions. We're bringing our members together, as you saw Friday night, to drive change. And so be active, CED, be active, GCA. Let's bring up those issues. Let's work on those. So thank you for the question, though, and thank you for pushing us, because we need to be working together. It was an excellent question. By the way, our international guest, as we've had the privilege of having lunch 2:30 to 3 next door, is true today, so we need to get over there. So we've got the next panel coming up in a half hour, but Manish, take it away.
So I'll be brief, and I'll just say a couple of closing comments. Healthcare is complex. healthcare is fragmented. It's actually scary to be a consumer of healthcare. And I really love what Jitendra said. If we can think more like some of the commonly known technology companies, you think of the Apples and the Android that have worked really hard to engineer complexity out and simplify the user experience. If we can create more models like what Jitendra articulated and regionalize them and make them available so that health systems leaders are able to focus more on delivering a better user experience, on quality of care. That's really what the future looks like. And I will tell you, and I will put a challenge out there. The reason I do what I do, remember I told you I helped build a stroke center in Abu Dhabi? 18 months later, my mom had a stroke, and still choke up when I think about this. For 12 hours, she did not have a CT scan done when she went to the hospital. Something is fundamentally wrong here where a patient who has a stroke, who presents to an ER, does not have the basic standard of care done. So what I will say is that we all had that one reason to drive change in healthcare. We talked about leadership as the key component of this. And I would challenge that each one of you is a leader. And we need you to reach deep within and think of that one reason and fight that hard battle. This is not easy. What Jitendra has done, it's not easy. What Tom has been doing is not easy. Not easy. What Dr. Majroo has done, it's not easy. What Dr. Agarwal has done, it's not easy. But it can be done. And we're all in it together. So I really thank you for your attention, for the participation, and enjoy your lunch.
Dismissed.
At the Women in Clinical Engineering panel, and I'm really happy to have you here because this time I want to share with you what we have done during the year under this fantastic project. And together with my fantastic colleagues that we are here, we are going to share our experiences and our thoughts about what it means to be women and clinical engineers, right? So without any waiting more, we are going to begin, and I'm very thrilled to present to you the WISE project, the role of being women and clinical engineers. This project, as I said before, has settled at the beginning of this year by an initiative taken by some of the group of the Clinical Engineering Division that were curious about what we are doing in our professional careers and also in our personal ones. So this project is composed for a group of engineers from all over the world, as you can see here. These are the first ones that were interested in forming this group. So as you can see, we have colleagues from Africa, from the Americas, from the Mediterranean region, Asia, Europe, and West Pacific. We are representation from all over the world. Although some of us are from one region than others, the project is open to all of you who wants to join. So, and then the other important point that I want to say is that each of them are leaders in their own paths, leaders in their country, and also are dealing with their personal lives, as all of those do, and their professional ones. So, the project arose considering this situation, women and STEM. And you know there are some key factors that key factors that form barriers to the gaps between genders when we talk about STEAM. So among others, we have gender stereotypes, and we have heard some stories. Yesterday we have a special session in Women in Clinical Engineers, and talk about these stereotypes and cultural things that doesn't allow women to express out their potential in some places, right? So another point is the male-dominated cultures, where some professions are named to be designed for men, you know? We talk some of the very strong idea is that it is a profession, but we can see now that in particular biomedical and clinical engineering is not necessarily only a male profession. Fewer role models. We have an important and interesting amount of female professionals in leader position and with great influence, but they are not enough. We need more, because we have a lot of things to cover around the world. And there is a situation very interesting here that is related to math. There is how to say that, a sense of anxiety when it turns to mathematics more than any other science, no? And I know at this particular point there are many important efforts at global level to deal with anxiety in maths, not only for girls, but also for boys. But the fact is, this is a barrier that prevents women or young women to take engineering as a professional career. So women are underrepresented in the STEAM workforce, and there is some interesting data. Yeah, only around 21% of engineering majors are women, and only around 19% of computer and information science majors are women. So we are under 20% representations in these fields. In global level, 80% of the healthcare are women. Only a third of the doctors are women. What it means is that we have a workforce that is growing and it's getting strong, but it's not still well represented in all the possible environments in the health system. No? And 38% of women in computer, 38% of women who major in computer work in computer fields. Yeah, and only 4% of those who major in engineering work in the engineering field. It also means that we have a lot that is not well provided to the health systems. Yeah? We are losing important systems because of this. And you know there are several reasons that it happens, but the fact is this. So, Women in Clinical Engineering, otherwise project, brings a unique perspective, skill set, and dedication to the field. And to express to the world the value we provide to the clinical engineering field. No? And we are aiming to find and to develop a strategic resource in shaping healthcare technology management, assessment, and other clinical engineering fields. There are some places where the dominated clinical engineering positions are females. One of these places is my own country. Yeah? In my country, all the chiefs of the biomedical engineering departments in the major hospitals in the whole country are women. And it has not been easy. Yeah, it took a lot of time and a lot of effort to reach this place. So it is possible, that's the point. So what is the capabilities of women that makes them important in clinical engineering? Driving innovation, improving patient outcomes, executing efficient health technology use, a strong problem-solving skills, and you won't let me fool you. Each one of us have deal with different kinds of problems, and somehow we have resolved it. No? Not only at the hospital, but also at home, but also in everywhere. And critical thinking, attention to details, and we are promoters of collaboration between all our colleagues at the hospital or the health system. Also, high level of empathy and understanding. And sorry, guys, but this is a female nature characteristic. So we have enough to do it fantastic in clinical engineering. So I want to share data that I think regarding the presence of women in the clinical engineering division of the IFMB. As you can see, we are fewer than our male collaborators, but we have presence in the 6 regions. Yeah, we have to improve this presence in some of them. But the point is, I have at least one college that works in clinical engineering in each one of the regions of the world. But the problem is that our impact has yet to be fully acknowledged, partly because we have not taken the time to recognize ourselves. And the WISE project is devoted to gather around to talk about our, not only our problems, but also what is around us as professionals in the clinical engineering field, and find ways to better perform as a group, as a collective, into the health ecosystem. Yesterday, I talked about Healthcare 5.0, and if you can see the capabilities of WISE, it is a perfect match to Healthcare 5.0. So we have an opportunity to consolidate the presence of women in the clinical engineering field. And we have the following goals that were set at the beginning of this year. One of the important things is that we have to promote the contributions we do to the system. Yeah? I know each one of you have been working very hard and have been successful in their own professional paths. But the problem is that we don't have evidence on this, more than the stories or more than maybe some social media, you know? But we don't have enough evidence, and we need it in order to have a support, a repository that supports everything we do and take it as a basement to move on. So we want to promote the conscience of each one of us. Our other objective is analyze the participation in the different environments of the health system, not only in hospitals. Some of us are working in academia, some others are working on the ministers of health at different levels with different responsibilities. And each one of us, what we do is important. So we want to analyze this participation in order to find new ways of doing this and also new ways of participate in these systems. Recognize trajectory. Yeah? Some of us have a few years on the field, some of you are novices, and each one of contributions are important. So the recognition, the trajectory of our colleagues is also a key point to the WISE project. And also encourage not only the participation of us as a female in clinical engineers, but also of our male colleagues in order to have a harmonic system that helps us to move on and to progress in this field. And then also to encourage young people to study these fields, these disciplines, right? So, in order to fulfill these objectives, the WISE project has 3 main activities that were developed along the year. One is the call for case study and stories. There were 3 callings for this initiative where our female colleagues and also some male colleagues send contributions, send their stories about the everyday work in the medical environment as a woman and clinical engineers. We also were working in a repository of the publications of our female college because it's important to have in one place all the information to be accessible for everyone. And a third activity, we call it Wise Your Lens. It is calling for having images that represents what we do in every aspect of on our professional path. So these three activities were developed along the year, and it began as a representative for each region, grew up to 19 members. Today we are 25, and I hope we could be even more. And well, these are some of the results of these three activities. The case studies and the stories have these inputs along the three callings. Obviously, the first one was the one who received more contributions, but the important thing is the distribution of the origin of these contributions. As you can see, from 20 countries, from almost all the regions, we received very nice contributions about the stories and the case study. In the first one, we had 10 case studies and 19 stories. And some of the recurrent ideas we received along these three callings are this one that I've shown. Challenge for a woman in a male-dominant field. The weight of being the first clinical engineer in the region, in the country. Yeah? And I can say that it is my case in the hospital where I had the opportunity to work. The support of our younger sisters. Yes, we know that we have a path and somehow we have made it, but behind us there are little younger clinical engineers to be that needs our support. The complexity of balancing personal and professional lives. Yeah? The need to acquire new tools to improve medical care through technology. We can detect it and we can expose it. Yes? The effective communication with health stakeholders. Yeah? Even though we may have the tools, the empathic tools, the comprehensive tools, sometimes it's not enough. The urgency of the problem-solving culture. Yes? We always are solving problems that had to be done by yesterday or by the day before yesterday, right? The consolidation of professional groups outside the natural borders. And this is one of the most important objectives of the WISE project. We may have our strong group inside the hospital, inside our own country, but we need to open the doors to the whole world. Yes, the more we are, the more diverse we are, the stronger we are. And skills more than strength. And there are several interesting stories about this last one. People that seems to be not strong and not physically speaking to do something, and somehow they solve it. So it is not an excuse. So in this slide, I rapidly expose the results of other resources. And in brief, 69% of the abstracts that we found in the last two international clinical engineering congresses are from male authors, and the 31 are women, right? We have some other results here, but important is this one. 31% of abstracts include at least a woman among authors. And from this 66, the 21% is a woman, the first one. So we have the potential to improve our presence in this kind of events and in other fields, in other sources. So these are the results of the WISE project. And now I want to share the stories of my colleagues that are here with me, and thank you so much for accepting the invitation, and to talk about these things a little deeper. And after this, I think we will have a few minutes to open the conversation to you and try to look together for better ways to make a difference at the WISE project. So the next presentation, I think we're going to change a little the things, I'm sorry, but I have two important engineers here that I really, really want to give them enough time so they can express themselves properly. So we are going to begin by Prashinska Vlak, here, of course, and Empowering Women in Clinical Engineering, a case study of Nepal. Can we see this? Yeah, please. Thank you.
Namaste. Good afternoon, everyone. My name is Prasiksha Ulak. Today I am representing Nepal, and currently I am leading Department of Biomedical Engineering at one renowned hospital in Nepal, Nepal Medicity. So topic, empowering women in clinical engineering, a case study of Nepal. So gender equality and women's empowerment, it's crucial in all fields, including clinical engineering as well. And by providing equal opportunity to female or women, one can ensure or one can harness talents a woman has and promote them. And I think it's give better results on the patient cares and innovative solution and give a more equitable healthcare system. So thus today, in this fifth International Clinical Engineering and Health Technology Management Congress, my presentation will provide you the historical overview of the condition of women in Nepal, their obstacles, their experiences, and their achievement as well. So let's move. This is overview of women in Nepal. Currently, Nepal is marking on 30 million population, and among them, 30 million populations, 51.02% are female, whereas 48.98% are male. You can see that female population is slightly higher than the male population. Though its woman population is slightly higher, going to the literacy rate, it's found that only 57.7% women are literate, which is 20% lesser than a male. So about the labor participation, how many percent of women are involved in the labor participation? It's just a 26.3%, whereas of male it's 53.8%. You can see that slightly, though the population is slightly higher side, the literacy rate and the labor participation is a lesser side. Why so? Here, this is the percentage of male manager and a female manager we have in the Nepal according to different occupations. It is found that 70.3% are male manager, whereas 29.6% are female manager. And accommodation and food services, that has the higher female manager, it's 40.3%. And going to the technical activities like engineering or something else, it's just 9.8% a female manager. And I must say that I'm among 9.8% of the population. So it is the higher education enrollment, how the enrolls are happening between different subjects, like among female, most popular subject is education. There is 67.1% are the female students. Now talking about the engineering, it is found that 15567 bachelor students among only 21.4% are women. So you can see differences. So let's go on the then biomedical engineering. How many are female biomedical engineer over there? It's according to Nepal Engineering Association, till 2017, 17,000 are the registered biomedical engineers. Among 17,000 registered biomedical engineers, only 323 are the biomedical engineers, which is just 1.9% of the total registered biomedical engineers. And talking about the female biomedical engineers, it is just 35.52% are the female biomedical engineers. So why so less number of biomedical engineers? It must be the questions, because only since 2009, Nepal has started to get own registered biomedical engineers. From 2005, there is a college of biomedical engineering affiliated to Purvanchal University, which started their course on the biomedical engineers, bachelor in the biomedical engineers. So till 2022, 541 are the registered biomedical engineers, and among them 191 are the women. So if you see the track, this is the enrollment, percentage of the enrollment of female biomedical engineers. Surprisingly, in 2017, it is found that 22 are the male and 21 are the female. In the 2017, it's just craze for the biomedical engineers among the females, a little bit higher. So now, let's go deeply on the female women clinical engineers and biomedical engineers. How many of them are there? I have just listed out and tracked what they are doing here currently. That it is found that 70% registered women biomedical engineers are settled abroad or settled there. For the higher education, they went there. And the 59% of them are working as a clinical engineers. But one of the proud moments for the Nepal and for the women clinical engineers in the Nepal is that most of the major and the prominent hospital in the Nepal, like Bir Hospital, Teaching Hospital, and KMC hospitals, Nepal Medical College Teaching Hospital, APEF, there are 90% of the major hospitals has the female leading the department of biomedical engineers. Though its a number was less, but the 90% of hospitals, there are the female biomedical engineer who leads the department. So I am the one of them. So let's start. For me, I already mentioned you all that my name is Prashiksha Ulak, and I have completed my course on the Master in Biomedical Engineer from Moscow State of Technical University, named after Bauman, in 2012. And when I started and when I get to understanding what's a biomedical engineer, at that time there was no college or no any university which can provide a course on the biomedical engineer. So for that, in the 2004, I went to Russia for pursuing the education on the biomedical engineering over there, and I have completed there on the master degree also. So currently, I'm working as head of the department of the biomedical engineers in one of the very renowned hospital, Nepal Medicity. It is one of the first NABH. I think you all are so familiar with the word NABS, National Accreditations Board of Hospital and Healthcare Services. It's first aggregated hospitals over there. Only 2 hospitals are NABS aggregated hospitals, and I'm there as a leading. And previously, before Nepal Medicity, I was in the Kathmandu Medical College Teaching Hospital for more than 8 years, leading the biomedical unit chief there. And I was the one who created the department on the Kathmandu Medical College Teaching Hospital. There was no biomedical engineers, there was nothing like that, and I entered there. I created a department. I gave them the values of the biomedical engineers over there. What will be the changes after having the biomedical engineers on the hospitals? So I have so many experiences on the working on the different level of hospital, from Nepal Medicity, which is the private sector, who focus on the patient services, and I have the experience on the Kathmandu Medical College Teaching Hospital, which is just a public hospital, and I can say that how the medical equipments are managed in the different level of hospitals. So as a role of HOD in the Nepal Medicity, it's my role to take a responsibility of a department, and I have 6 team members over there, and among them 2 are the female. And before this attending the Congress, I interviewed the 2 candidates for the biomedical engineers. So after this, we will have the 8 team members, including me, there is a 9. So I must say that in Nepal, this much of a team of 8 team members and leading the department is one of the very good conditions and very proud moments for us. So this is Nepal Medicity Hospital. I already mentioned you all. This is the first NABH accredited hospitals, and it's stand tall for its patient safety, patient healthcare standards, and it has a very team of the renowned doctors teams, and it has a very good team of biomedical engineers, and of course it has a very pre-hospital care services with the well-equipped heli-rescue and the ambulances as well, and it has a very well-settled ICU units, critical units, where there are sophisticated, updated, and very standard medical equipments. And as a biomedical engineer and as a clinical engineer, I'm so proud to mention that I'm leading such hospital. So, what to attract women to enter the field? It's according to some research and everything, it is said that women are good at math and science. I don't know how many of you agree on that, but it's found that women are very good on math and science. And it's women are socially responsible, you know, they can give us the impact, their actions give us the impact on the society, and they are very creative as well. And talking about the medical equipments, it's aging population, it's medical equipments, it's just they have to need maintenance, repairing, and these are the updating medical equipments. First, there are so much job security in the field of medical equipment as well. So there are so many, as seeing on this, creativity science and the job of it's aging population of medical equipments, there are somewhat women are attracted in this field as well. So what are the advantages of gender diversity if we have the gender diversity? It is said that it's enhanced problem solvings and innovations, it's a comprehensive understanding of patient needs, and expanding the market reach. Women can expand the market reach, I think so, and improve dynamic and collaborations, and reflect the society diversity also, and attract and retain top talents. I already said to you all, and enhance ethical decision making as well. So these are the advantages of gender diversity in the engineering or clinical engineering, whatever, it's an advantage. But I already said what to attract this also, but there are some obstacles. Then why there is no any participation of women in any of the fields? There are obstacles. What are the obstacles are there? It's a cultural and a social attitude. You all agree, I think so. And due to it's saying that engineering course is not for the female, it's for the male. Male is, it's a very hard subject for the female, it's said like that. And in the field like the clinical engineering, there are lack of role model, and it's guidance for the female, career guidance for the female also. And of course, engineering course is expensive as well. And most of the female, like a country in the country like Nepal, the female depends on for financial support, female depends on the male. So as a course is expensive, it's a little bit, they are hesitant to pursue the career in the engineering. And if they try for it, for higher education, they have to leave their home or they have to leave the country as well. So these are the very few basic obstacles that women like in Nepal is facing for pursuing the career in the clinical engineer. Now, all the obstacles, they completed all the obstacles, they pursue the education on the clinical engineering or biomedical engineering, but it is found that though they completed graduation in the engineering degrees, it is found that 40% women who completed graduation in engineering either quit or never enter the profession. And these are the very serious topic, and I don't want any debate on this. It's because of the sexual harassment in the job, and because of the menial tasks they received comparing to male counterparts. And there is always one question for the female: can you handle your family? Can you handle your child? Can you handle your home with this job? I think most of the females face this question frequently, and very little support from the network or the society or from family. I'm lucky enough that I have the very good supporting family. That's why I reach here. But very few of the female, they receive these supports. And these are not only the points that I mentioned is theoretical base or it's a practical base. As a woman, I also face very of these obstacles in my life. So you can see that the participation of women in economic activities in Nepal is increasing. But what's the ratio of the salary or income? It is found that for the same job, for the same tasks, women are paid 20% less salary than of male. But one thing, it's not. It's for me, now I'm the highly paid biomedical engineering in Nepal. Though I am the female, I'm among all the biomedical engineers, I'm the highly paid, but it is 90% this has happening. So what should we do to close the gender gap? I must say that it should be start from the family. Family should understand the education for their girl child, and then the society should need to change the thoughts of society, things of society, how they react for the female, and then of the country. So encourage female in practical-based engineering education from the school level, and aware about their role as a potential leader in the society, as to incline them toward the economic developments of the country through education, to make their life independent, and to change the radical thinking of male dominance. This should be happen. And policy implementation for reservation system for the women, and a political commitment for the participation of female in the national development, and of course allocate sufficient funds for the upliftment of the clinical engineering course in the country. These are the few points that I want to highlight. And of course, as a biomedical engineer, as a clinical engineer over there in Nepal, whatever these top points I have mentioned in the presentations, I want to share one experience with you all. I just joined the previous hospital at Kathmandu Medical College. I was new there, and for just 5 or 6 months, then I went to my immediate supervisor for some approval, to take some approval. And there was the communication between my immediate supervisor and one of the boss. And one of the boss was asking my immediate supervisor about my performance, how she is doing, how she is. I was there in the door, and I heard my name, Prashiksha, mentioning. So I just listened there, what they are talking about, and the boss was asking my immediate supervisor about my performance. Then my immediate supervisor mentioned that, yeah, she is doing good. Okay, she is trying hard, she is doing good. Then the boss who was asking question to my immediate supervisor gave us such a deteriorated comment about my appearance that from the next day, I started to wear a loose-fitting dress, So this is exact scenario. This is what is happening. Though one should be always should be, it's depend upon you, how you take. Always take positivity. Just put negativity on the aside and move ahead. I have very supportive family, I have very supportive in-laws, and I have very supportive husband. Even my son is so supportive to me. Luckily, that's why I'm here today, presenting Nepal. Otherwise, many of them, whoever entered the field for the biomedical engineer in the hospitals or whatever, they had to quit the job. But I'm here, and I'm proudly presenting there today in the Nepal, and I'm always again saying that gender equality and women's empowerment are crucial in all fields, including clinical engineering. By creating such environment, providing equal opportunity, one can challenge gender biasness and harness very potential talents of women's talents and expertise, leading to improve the healthcare solutions and more equitable society, I guess. So, thank you.
Thank you for your extensive, fascinating exposition about these factors that sometimes characterize us also as clinical engineers. Now we're going to hear Kavi. It's another point of view of this topic. So welcome, Kavi.
Good evening, everyone. And it's Vanakkam from Tamil Nadu. I'm Kavi Bharati here. I'm going to talk to you about women clinical engineers of Tamil Nadu, an analysis of Tamil Nadu women clinical engineers, education, career progression, and the solutions to overcome the hindrance faced. First, it is career progression of me, and it's my team. I have conducted a study among the women clinical engineers. It was done by me, and hailing from a small town in southern part of the Tamil Nadu, Srivilliputtur. From there, I got inspired by the biomedical engineering field, and I completed my B.Tech degree in 2009 and completed my M.Tech in biomedical engineering in 2011 from SRM University. So traveling from a small town to the city itself was a prime challenge for me, which I have overcome through my constant support with my parents and everybody, because a girl from a village coming to a city itself a big challenge in those times. And coming from there till today, I am presenting here in this conference is the greatest achievement of my lifetime. I think it is I'll take it as a sportive thing, and I'll pursue my further studies in clinical engineering. Then coming to the description, I have conducted a study in women clinical engineers of Tamil Nadu, and for understanding the education and career goals and opportunities of the women clinical engineers. The study is actually done with the women clinical engineers of both private and government sectors, field biomedical engineers, and the challenges faced by them. Possible solutions to overcome the challenges faced has also been discussed, and future plans of the women clinical engineers of Tamil Nadu is also being discussed here. And the targeted study about women clinical engineers is done on a field biomedical engineer and engineers of private hospital, and the engineers who work as a field engineer in various parts of manufacturing unit, and also with the suppliers and dealers. And the goal of the project is to identify the goals, identify the top 10 challenges and opportunities of women clinical engineers of Tamil Nadu, and networking and advocating in women clinical engineers of Tamil Nadu. In the end, the result will be definitely useful for the women clinical engineers of Tamil Nadu. And women clinical engineers of India, generally, women is a multifaceted. As everyone knows, she has to take care of the home and the society and also the career. The upbringing of the child is totally on her, and the career advancement is also totally on her. Whatever the challenges she faces, she has to overcome, and she has to excel in everything, and she has all the capabilities to excel and compassionate ground everything she has, and she can actually bring laurels to her company or the field which she belongs. And being in India, and now I am very proud to say that we are on the moon, and it's all because of our technology and science is getting great achievement. And in the Chandrayaan 3, 54 female engineers were working, and we are on the moon, and it's very proud moment for all the Indian people here. Next, about women clinical engineers of Tamil Nadu, the first of a kind of woman clinical engineer. She is an electrical engineer. She passed out from COE Gindi, that is College of Engineering Gindi, and her name is ICEHTMC Lalita, and she was the first engineer of Asia from India in electrical field. The following women are who created history in engineering, and they are also mostly based out of Chennai. And so I was here to say that during 1950s itself, the women are in the clinical engineering field. But still we are lagging in clinical engineering, because we cannot get a proper leader in women clinical engineers. And biomedical engineering in the state of Tamil Nadu, overall percentage of engineering graduate passing out every year is 40% of male and 60% of female, because female, they took the biomedical engineering as a very base field and they enroll in the courses like biomedical engineering and bioengineering. But when it comes to the job, 80% of the male are getting placed in the core field, but only 20% of the females are there in the cold field. That is, clinical engineers are very low. Women clinical engineers are only, we can count in numbers. Though we have 200 and above engineering colleges in India, in Tamil Nadu itself, but we cannot find a female leader in a clinical engineer. And the persons who are pursuing biomedical engineer, you are studying in the biomedical engineering field, are mostly tempted to shift their core field only because of the salary and the challenges faced here in clinical engineering field. I wanted to set up as an example of achieving in clinical engineering field. Though I got placed in Tata Consultancy Services, which is an IT-based company. When I got the opportunity in the field, and which is very much low salary compared to the IT field, I shifted my job because my passion is towards biomedical engineering, and I have done a master's in clinical engineering, so it is better to explore the thing, and I wanted to set an example for the other girls who are there pursuing clinical engineering. And you can see the graph over here. This is for past 5 years. The students who have enrolled in biomedical engineering in Tamil Nadu, you can always see that female engineers are more than the male engineers. Tamil Nadu being the state-of-art thing in the medical tourism, and Chennai being the capital of the medical tourism in Tamil Nadu, really requires more number of female engineers and biomedical engineers in the field. And this is the job roles of biomedical engineers of Tamil Nadu. After the graduation, what they are doing is they will be like a field service engineer, application specialist, service managers, maintenance engineer, procurement engineer, product specialist, and etc. Here in this chart, you can see that 22.6% are field service engineers and 25.8% are maintenance engineer. Maintenance engineer is that the people who maintain the hospital equipment in Tamil Nadu. And the girls are usually placed as an application specialist and procurement engineers. And this is about the survey. The survey is all about the career progression and the opportunities provided. The survey has been done between the age group of 21 to 38 years of age, and the education of the women clinical engineers have been analyzed. And the reason for them to quit the field or to stick to the field are also being analyzed through the questions in the questionnaires of the survey. And the most common reason to quit the job and the expectation of a woman clinical engineer from their bosses or the employer is mainly discussed. And this is the percentage of UG and PG of women clinical engineers. That is undergraduation. There are 71% of people who do undergraduation are now in the job. 29% of people who are in a job now they have completed their post-graduation. The common reason to quit or the shift job will be just wanted the salary hike, or the people who, as my previous presenter says, girls will be dependent on the men to run the family and for the salary aspect. So after completing the engineering, when your peers and the neighbors who are getting salary very much higher in information technology thing or any other engineering is not equal to the clinical engineers here in India. So they mostly wanted to shift the job. The person or the women clinical engineers who definitely are very passionate about the field only can stick to the clinical engineering. Next, it is the challenges phase. There are many challenges analyzed. I wanted to highlight about the challenges because when I was asking for the thing why they wanted to shift the job, they mainly feel not appreciated. So anyone who is doing job, if they are getting appreciated, they'll get motivated and they will be furthermore encouraged to do the thing. But here we can see when I was asking the questions to the women clinical engineers who are in the field, they were like most of 35.5% of the people, they said they are not getting appreciated. Then I have started asking the questions furthermore. I've got a form in that I have given 10 more points why they were not appreciated. It is their replies for that. That is 50% of the people have done that their works were not acknowledged. And most of the people, after that you can see 28.6% their works are being overshadowed by the people or the employers or the peers. Now, opportunities given to the women clinical engineers in the workplace scenario, they feel it is not same. even though when they give the job, when opportunity is coming in the organization or in the hospital is not same, they will get demotivated. And gender bias, as already discussed, gender bias is not only in clinical engineering, it is in all part of the engineering, all part of the word now, I guess. And responsibility. So comparing to the previous slide, it will be slightly different because opportunities were not given, but the responsibility's sake, women are considered more responsible than men, so equally they are treated with any responsibilities without any discrimination. Challenging parts were also given, so what the people will think, so they can manage, they can be responsible, but they cannot given a higher position in an organization as the gender discrimination comes over there. And this is the top 10 challenges faced by the women clinical engineers of Tamil Nadu. It is gender discrimination, workplace hours flexibility, biased work application, restriction in recruitment, compromise in sanitation and restrooms, traditional restrictions, infantilization of women, lack of support, lack of mentorships, and lack of women role models, and communication barriers. In these 10 points, I just wanted to highlight about the workplace and hours flexibility. So women in general, they wanted to take care of the home also. So they can be given a flexibility in working hours. Their peers can understand their work responsibilities in home, and they can be given that work hours flexibility. And restriction to recruitment, this is a very important and challenging thing now, because when I was discussing about my recruiters, when I was asking for the survey, they were telling that they are not in the mood to recruit a girl. It was very challenging, and they are telling it to me. I am the biomedical engineers of a renowned hospital in Chennai. But to me, they themselves will say, ma'am, we cannot recruit a girl because we have so many challenges with them. We have to send them home soon, and we have to give them many holidays, maternity holidays, everything is there. So they were reluctant to recruit a girl for a woman clinical engineering job or any sort of service job in clinical engineering. And this attitude has to be changed in the field. And about compromise in sanitation and restroom, and I don't think so most people will discuss about it, but we female engineers, we require a separate restrooms for that, restrooms for everyday's life, because I encounter the same problem. When we go for hospitals, here in Tamil Nadu, we biomedical engineers can handle more than 1 or 2 hospitals, so we cannot stick in an office where we have restrooms and all. So when we shift to other hospital, we cannot go up and ask everybody to where to use and all. So it is very mandatory for all the employers and the government out there. I wanted to tell them that you have to definitely have a separate restrooms and proper sanitation, everything. When we are very much improved in science and technology, this is a very basic requirement. I don't think so anyone will discuss this about this in their field or not, I cannot understand. As it is a male-dominant field, I want all the male recruiters and the organization top-level leaders, everybody should think about it, and they have to even give the space for women clinical engineers, and they have to understand their basic problem. Then about lack of support. It can be either in the family or in the family organization also. If the family is not supporting a woman clinical engineer, she cannot even perform well in the office, I guess. If you have a good support in the family system and in the society, you can excel in all the works you have been allotted. And I can give myself as an example. During COVID times, I was left alone in my organization, and we were only 2 biomedical engineers. We have to maintain all the ventilators, all the equipment, because no service support or no service engineer technician were coming to the hospital, as it is a COVID hospital, 3,000 bedded, and we are receiving enormous amount of donations, equipment, and repairs, everything we have to handle. So we are only 2 there. And daily it will from 9 to 9:30 or 10 we will work in the night. So there has to be someone, there has to be support in the family to take care of my kid. After working in a ventilator in a COVID ward, he cannot go to the home directly. And if my husband is also in abroad and I cannot stay in hospital also, I have to take the family responsibility. So it's my family support. I left my kid with my in-law, and they will be in a separate room, I will be in a separate room. So daily I have faced all the challenges. So that is the time where I get my confidence. And I thought I can do and I can handle everything. So it is not like women should be dependent on men for all the things. Women can handle anything. So I request the world to believe women and that she can handle everything. So you can give more responsibilities to her, so she can excel in this. And communication barriers coming to me, coming as a main challenge here when I took the survey is, most of the girls or the women clinical engineers, they are not voicing out. So if like Pratyuksha said, when there is a sexual harassment or when somebody is talking little different with you, you can just voice out. It is nothing wrong in voicing out and helping your peer or whatever, whoever it may be. Even he may be your boss or whoever, you can just tell them it should not be done with me, and you are not to do like, you do like that. So if you are voicing out, they will have a second thought. So we should not repeat it with any woman. So I actually appeal all the women clinical engineers, all the women here. So whenever you encounter such sexual harassment or any type of verbal harassment, you can just voice out. Then about ideas to overcome the challenges is perseverance, determination and self-confidence, constant upgradation of knowledge through continuous education. If you are upgraded in your knowledge, no one can deny anything from you. In everything they will consult with you, because when you want to make your presence inevitable, you have to be on track. You have to be on track with all the science and advancements in the country. And future plans of WCA is, I wanted to create a forum or association for women clinical engineers in India and also in Tamil Nadu, collaborating with all the international forums, and conduct webinars and motivating speech by women trailblazers. As we don't have any women role models here, after coming to this Congress, I saw many of women are very exceptional in their profession. I want all of you to help me, guide me in bringing up my Women Clinical Engineers Society of Tamil Nadu. So I request everyone over here to support me and join with me to help my Tamil Nadu and India to excel in women clinical engineering. Thank you.
I love to hold my college because it's so emotional, it's so inspiring what we have seen now, right? We have two more contributions from authors that couldn't be here with us. I would like to share them with you because I think it's important to hear their voices even though they are not here with us in presence. May I have the 112, please? El Assam, Sudan. Okay, here it is, a presentation from Amna El Hassan, and the title may not be more than adequate, right? Motivating message for women. Well, they say, we will explore the journey of a woman in the field of clinical engineering. She will share her experiences, insights, and discuss the importance of empowering women in this dynamic field. Clinical engineers, female clinical engineers will gain inspiration, confidence, and insights into overcoming challenges with the goal of increasing women's participation in clinical engineering. Healthcare institutions will be encouraged to embrace diverse talent, leading to innovative solutions and engagement in clinical engineering departments. Educators and mentors will be motivated to support and guide female students and professionals in clinical engineering, fostering a network of support. And this presentation aims to contribute to a more diverse and inclusive healthcare industry. So the results that she shows us is the increased participation of women in clinical engineering, leading to a more diverse and innovative healthcare sector. Improve access to mentorship and support for women pursuing careers in clinical engineering. Greater awareness of the challenges women face in the field and the importance of breaking barriers. And enhance problem solving and innovation in healthcare, positively impacting patient care and medical technologies. It's a brief message from Amna, and it's important to listen to her also because she talks about another topic that complements what we were hearing today, that is the mentoring. Some of our colleagues were mentioning the importance of mentoring, and in that regard, I'd like to comment that one of our prioritizations for 2024 in CED will be mentoring. So we are going to develop a project to attract women in clinical engineering and also men clinical engineers to form a mentoring group in order to fulfill some of the objectives we shared at the beginning of this session. So we have another paper from Bangladesh. So please, can we see that 49? We also review it the same way that we did before. Okay, thank you. From the Bangladesh, this is the necessity to introduce women clinical engineers in the modern hospital of Bangladesh. Okay. Well, this is the team of this, the authors. And they say, this project addresses the critical shortage of clinical engineers in the healthcare system of Bangladesh, particularly focusing on the underrepresentation of women in this field. Yeah. There is a significant gender gap, in this profession, and women are not adequately represented. This project aims to highlight the necessity of introducing women clinical engineers into hospitals in Bangladesh. And it begins by examining the current state of the healthcare systems in the country and emphasizing the importance of clinical engineers in improving quality. The reasons behind the gender gap in this field are explored, including cultural and societal factors, lack of education and awareness, and discriminatory employment practices. This project argues that introducing women in clinical engineers is crucial for several reasons. Women make up a substantial portion of the healthcare workforce and can bring a unique perspective to the field. Their inclusion can contribute to more innovative and inclusive solutions. Increasing the number of women in this field help address the gender gap, promoting diversity and creating a more balanced healthcare system. And women clinical engineers can serve as role models for young girls, inspire them to pursue careers in science, technology, engineering, and management. The project also discusses the challenges that may arise introducing women clinical engineers in Bangladesh, and these challenges include the need for specialized education and training programs for women, overcoming cultural and societal barriers that discourage women from entering engineering fields, and promoting equal employment practices. So the goals of the project is to raise awareness about the critical shortage of clinical engineers in the healthcare system in Bangladesh and underrepresentation of women in this profession. Also aims to address the reasons behind the gender gap and provide recommendations for promoting gender equality in this field. Also, it highlights the benefits of introducing women in hospitals in Bangladesh as clinical engineers. Yeah? And the primary beneficiaries are healthcare system, of course, hospitals, patients, and aspiring female engineers. Okay? Patients will benefit from more diverse and inclusive healthcare systems that addresses their unique needs. And aspiring female engineers will be inspired to pursue careers in clinical engineering, leading to a greater gender equality in the profession. This project is, I understand this project is on the run, no? And by the objectives and the goals, it highlights the urgent need to address this shortage in clinical engineers and underrepresentations. And well, they recall the importance of diversity on the workplace, and the reasons of why this diversity is important. No? Okay. Some other reasons that supports the first arguments on the diversity and the representation of women and clinical engineers, and the perspectives and skills that women can lead to better outcomes of patients. That is something that we already mentioned for the other presentations. I think this also supports everything we had said. And I really expect from our colleagues from Bangladesh that as soon as they have results, they can share it with us, because it will be very interesting to hear what they found, okay? So I would like to take a few minutes now that we saw all these presentations to open the conversation. And firstly, I would like to invite some of our male colleagues that support us very strongly to share with us their thoughts, their feelings about what you have seen here. And the first one I would like to invite to talk is Mr. Shankar Krishna. Here it is with us, President of Vice President of UPESM, and a natural ally of women in clinical engineers. Welcome, Dr. Shankar.
Thank you. We have the leader here who is the chair of clinical engineering division. That's a good example, And in fact, even in our federation, we have many female biomedical engineers holding responsible positions. It turns out that I ask a simple question. In terms of population in the world, what is the percentage of women and what is the percentage of men? In fact, it is almost like 50-50. Sometimes the percentage of women may be higher, But if you look at the medical devices and the people who are designing the medical devices, that percentage of persons in the design stage, right? You talked about operational stage, is far lower, okay? I do not know if there are numbers already available or it was presented before, but that is not good, Now, how is it possible? I mean, a simple example I give is it's not easy for a man to really understand a woman in labor and delivery, to understand where you put the electrodes, and see the positioning of them and what goes through that, It's easier for women to understand. Okay, that's one thing. So the percentage right from R&D stage will have to be more because they understand from first hand what is the requirement. Okay. Then you come to manufacturing. In general, in manufacturing, the number of women, engineers has been fairly good, manufacturing quality assurance. But I walked in slightly late, I heard about service industry. Yes, I think the clinical engineer, in working in the hospitals, the numbers are not very high, and they have to increase. If you look at the devices, although doctors are interpreting the results from the patient data, it is the nursing staff who are going to be interfacing the devices. And percentage-wise, the number of women nurses higher in most hospitals. And they find that having female clinical engineers train them much easier. It's much more comfortable, placement of electrodes or, going through mammography, whatever the case may be. I think they are more receptive, and we do need to have more female clinical engineers. And then regulatory aspects, there should be more of them. And in associations taking part in this, as well as in government roles, I think there has to be a greater policy makers who should be representatives in them, right? And because we are all equal, there is no, and I think United Nations Sustainable Development Goals as the gender equity as one of the requirements, So we need to not simply talk about it, I think, fortunately for me, I have had students in the undergraduate, masters, and PhD. I've had more female PhD students than male students. And in general, if you look at the statistics in the US, the women biomedical engineers is increasing. Steadily it is increasing. Okay? And I think the trend is good. People are getting more aware. And to the points that you brought up, at home, since I'm also from India, I understand some of the, existing cultural procedures, practices. And it is prevalent in many parts of the world. However, I think it is changing. In US, there are many men who are taking care of the babies, and the women are going to work. They're all equal. I think I also saw in the slides, about empathy and so on. I think having them is good. And in general, in my own class, when I taught, we had almost 50%. And whenever there are female students in the class, the overall performance increases. Everybody wants to excel. Okay? So I think there is no doubt we do need more than what we have right now. It is absolutely essential. Okay? For us to have, we talk about diversity, equity, gender, equality, and all that, but ultimately we want to have the best service. If our aim is to accomplish better health for all in the world, right from before a baby is born all the way to the end, I think there is no doubt we need more female engineers in all professions. But I think life sciences and related life sciences, the numbers are very encouraging. And very soon, I think you will reach the levels and they will go into leadership. I think there have been studies published about not enough women professors in biomedical engineering. Okay? Even that is being addressed. Also, people who are applying for research grants, they look at that, and that is also being addressed. And all these need to be looked at a higher level, and it needs to be brought to the attention of elected officials, because they have the power to make changes, and we need to take positive steps. The results may not come immediately. For any change, there is always going to be some positive and negative thing, but we need to look at the long term. And I believe, long term, we do need to have equality and contribution, so that will make the solutions much more optimal. And then we as, engineers working towards solving problems in biology and medicine will achieve the goal for better life. Thank you.
Thank you, Dr. Sharma. Sharma, I'm sorry. I'm sorry, Krishna. I'm sorry, Doctor. Well, we have a few minutes more. I'm going to take them because we began late. And before I give you the mic, may I have a few minutes to ask Mr. Tom Jod to share some thoughts about this project, since we began because of you doing these things, so we will really love to hear you.
Tom Judd is wearing out a little bit. Well, in the previous years before, my distinguished colleagues, see, I'm wearing out. Man, I am weirdly wearing out. Fabiola, we saw great promise in Fabiola a year before she became chair. And it didn't have to do with her being a woman, it's just her incredible professionalism. And so I think I'm telling you the culture of CED, I'm telling you the culture of GCEA. GCEA, I mean, who's the leading biomedical engineer, clinical engineer in the world? Oh, that would be Adriana Velazquez. And she's been an inspiration to all of us. And so our culture is to treat everybody equally and to encourage everybody equally. I think you heard my words yesterday, everybody counts or nobody counts, but I'm talking specifically about, how we look at our colleagues. So that's nice to say, Tom. What did we actually do when I was in the role that you're in now? And, we had webinars that pushed you forward, women forward, specifically focused on what women are doing. I think it was a 2-day deal among, many webinars. But we also pushed talented women clinical engineers into those other webinars equally. I mean, we can go back and do the count, but it was about your talent and your skills and your professionalism. It wasn't about your gender. So I think once again, what's the evidence? And I'm speaking now, I'm not the head of GCA, I'm the liaison director. Dr. David is the head. But I can tell you, we talked to Adriana from the beginning. She couldn't be on our board because of her role with WHO, but we talked with her from the beginning, and we have, all right, we don't have enough on the GCA board. We have 2 out of 12. Unfortunately, that proves out some of your statistics. We need to improve that. I think Keiko, you're in the room, right? And Shauna Mullally. But, we can continue to work on that. That was a small group, a startup group, but we can improve on that. So anyway, it's our culture to see you as our colleagues and our friends and equal to us. I can tell you in the largest health system, there's 2 large health systems in the U.S., particularly large, and I'm talking about 200 to 500 clinical engineers, or maybe that's 200 to 500 person groups. There's a lot of technicians and men and women. But anyway, I'm trying to talk about the Veterans Administration system in the U.S. And Kaiser Permanente. And I think after Mario Castaneda, in my last 10 years with Kaiser Permanente, Mario was my boss, but then Carol Davis Smith. I think I'm making a point. So in the Veterans Administration system that Huma, among others, that's here this week, Afghani background, but working in the U.S. in the VA system, caring about her country, which also demonstrates she's taking her volunteer time to try to work with this former Minister of Health that was on the panel with a little bit of help from GCA, to make a difference in her country. So that speaks to her heart as a professional and as a woman. That's an almost impossible situation, right? In Afghanistan. So, but women like, impossible situations, right? So, so what's my point is that anyway, we're doing everything we can, and you will help us do more as a GCA and as a community. So I hope I hope I'm walking the talk that, with evidence that we care deeply. So. And I promise to get a nap and do better.
Well, we have last intervention. Short, please.
Yes. Thank you, Tom. Always I mean short, not brief, not descriptive narrative. In key sense, sometimes doctor search the physician, and sometimes patient search the patient. Patient search the physician, physician search the patient. So we are male engineer, we always search and accommodate the women engineers. If we see our life, partnership. So despite a lot of barriers, we could not ignore the necessity to introduce women engineering. So it is my ending point. Whatsoever problem, we have a solution. Our president of IMB CD is a good woman clinical engineer. This our Bomir platform added some country policymakers like minister and secretary and make this open their sensor to sensing. What is the results with women clinical engineering from the patient and male and female? I think that rationalize, first I approach 50-50%, but it depends on investment of the money, country needs, country perspectives, devices, as well as passions. So I wish to approach and encourage the women clinical engineering and male and female clinical engineering should be rationalized. In all over the countries, patients, women patients always desiring the task of the women clinical engineering. Despite the ever and unending necessity, we are culturing and pushing the male engineers. So we need to break this barrier and adapt it our women clinical engineer. Thanks to all.
Thank you. We are about to finish, but if Dr. Sharma now allows a couple of minutes to listen to Millicent. Yeah? May I have 2 minutes to listen to Millicent before we finish?
Oh, yeah, yeah.
Oh,
sure,
okay,
sure,
so
sure.
please, Millicent, we want to hear you.
Mila is important.
Absolutely.
Sorry, thank you so much. I'll be very brief. Thank you so much, Fabiola, for what you're doing, and we are so glad for this initiative. I have a request for the next global conference that we have this session right at the core of the conference before the team leaves, because I believe that there's quite a lot of information that people are having that you can actually gain from. So my kind request to Tom Judd, yourself, and the rest of the team members, including myself, that we try to see if we can be able to slot it somewhere in between, right in the middle of the conference. That aside. And the reason as to why I'm saying that is because I want to make a call. And the call that I would like to make is for all the men in the room, that if we go back to our various countries, could we spearhead or rather support the women to form groupings of biomedical engineering? I'll just give a short scenario of what we have done in Kenya. And so in Kenya, we have an Association of Medical Engineering of Kenya. That is the bigger body that has all the biomeds in the country. And then under that, we formed Women in Biomedical Engineering Kenya that was launched like 3 years ago, WEBEC, we call it WEBEC. And through this initiative, we have seen quite a number of women join the biomedical engineering in the country. If you get the statistics, you will see that so many women have joined because they are seeing what we are doing in the country. So my call to all the men in the room is that once we go back to our various countries, let's support the women to form a side association or a side alliance or a side group within the major association in the country to be able to support the women. And with that, I think I'll be doing injustice to myself if I don't mention this, that recently, early this year in March, we also formed Africa Women in Biomedical Engineering Alliance. We call it AWIBEA. So Africa Women in Biomedical Engineering Alliance is an alliance that gives support to all the women in biomedical engineering in Africa, because this is an area that is really lagging. So we are really calling upon all the women to plug in during our webinars and our support, webinars and Zoom meetings, just to showcase what they are doing so that we can support each other to come up and, join our male colleagues and allies in this field in doing what they are doing. Thank you so much. Over.
Thank you, Millicent. And of course, you and everybody know, I want you to know that CED as well as GCA, although the boss is not here, but I can speak on his name. You use us as a platforms to develop these initiatives. The Alliance in Africa is a very remarkable effort that has to be replicated. Here we have another fantastic example of a group of women in the zone in India. So this initiatives we are looking for them, right? So please, if you feel that we can be useful for you to give them a voice, to give them a spot, please come to us, and of course you will have all the support and everything we have on our hands. So with this, I think we will finish this session. I would like to thank my guests here and invite them to share final thoughts if you want before we close our session. You like to comment something before we finish? No? No? Well, I think what they presented speaks by themselves, right? So thank you very much for being here in this session. We will try to do it even stronger and more prominent in the following events. I think the point has been settled, and the point is it's important to talk about this. So thank you so much. I invite you to join us in this initiative, the WISE project. If you feel that you can take active part in this, please come and join us and expect very important things for 2024. Thank you so much. Have a good afternoon.
Do we have Tom here? He's coming. Yeah, he's coming, he's coming. Let's see if Tom is there. Who told you? तुम भी चले जाओ ले आओ. कहाँ है? Tom is there. So Tom, we close the Congress? No? Is that? Should we close the Congress? Yeah. And there are a lot of people waiting for city tour, so as we move out, yesterday's group picture was very dark, so maybe we can take another one in the light. So, would you like to come on stage? Fabiola, remain on stage. Krishnan, please come on stage. Please, please. Dr. Krishnan. Sorry? Who? Ali on stage, and then we go out, and then we take a lovely picture. And there are no sessions in other rooms happening as of now. So some people have left from Vizag. Some are waiting for city tour in the buses outside. We will all go out, take a picture, but just waiting for Khalid to see if we can propose a vote of thanks to these lovely men and women who have made it possible. And Rimi, although you have not done much, but why don't you come up? She hasn't done much, but if you don't mind, we can have her on the stage. Except doing everything, she hasn't done anything.
Remy did something incredibly difficult. She had to represent your brain the last 11 months.
Which is not much. Callie. Is Callie there? Yeah, she listens to him more than anybody else.
We are good.
Huh?
We are good subordinates to the bosses.
In your case, I am the subordinate. You are the boss.
Someone record this.
Callie, please come over.
Faster, faster, faster. You are slow. Tom has been telling you that for a year now. So there are a lot of people waiting outside. We will be going out. But we have, gentlemen, if you can come over in the center of the stage. We did thank them during the gala dinner, but we have some wonderful men and women, angels here. Dr. Krishnan, who represents IFMBE, Tom Jude, who represents all of us and represents GC and things we do. We have Rimi, whom all of you know, the person who organized the entire event, Fabiola, the CED board chair, and also woman clinical engineer, a global leader, and Callie, who has been instrumental in the entire architecture of this program, all the arrangements, all the coordination. We formally take it as an opportunity to thank all of you for being here. I think we had people from over 67 or 70 countries. Last evening's house call, we got to know that 48 of them have come to India for the first time, and hundreds of others from India to have taken part in a fabulous program. Tom, any words from your side?
By the way, PhD biomedical engineering. You know, it brings great joy, I mean, I think to the whole community and to each of us individually to have been together and to engage and network and make new friends and hang out with old friends. I mean, I've been talking to several of these folks for 5 or more years and never seen their faces, and I'm so glad to have been together. And I've seen Mary's face before, but I like to see it. Even, you know, that's okay, her husband's right there, but, you know, so it's been a delight to be a part of it. And we all probably need a nap like I do, but, you know, we've left it all on the playing field.
Excellent. Dr. Krishnan.
Well, I think, as you said, I think no event will be successful without the participants. You know? So you are the most important persons, you know, to listen to all the words of wisdom you heard. I would just like to repeat one thing, and that is the United Nations Sustainable Development Goal 3, which is good health and well-being for all at all ages. And all of us can feel proud that we are all working towards, and we will work towards achieving the goal of United Nations Sustainable Development Goals. And it has got several other goals, but they're all interlinked. And this, if you look in the YouTube, you can see a lot of presentations on this. And as engineers who are working towards better life for all in the world, you know, across all countries, all religions, and all communities, we have a common goal, and we feel proud that we are working towards achieving this goal. And thanks to you for organizing this, and all of you, from on behalf of IFMB.
On the way back. So India is affecting our hearts and our minds and our dress.
Words come to my mind. Your warm hospitality and welcome is something that is unforgettable and amazing. Thank you for making us feel a closer sea family once more. Thank you.
Well, I want to thank for 2 fantastic days where I had the opportunity to meet you in person. And I take from this event a lot of homework, but also with confidence and with enough confidence to make greater things in 2024 and the years to come. Thank you so much.
Thank you so much. I think very fortunate to work with this man and getting such platform and opportunity, because what we all have come together for is a separate agenda, but why we have organized this and how we have organized this is another planning and set of execution, so which is another agenda. So I'm part of that agenda, both agendas, so I think I'm very fortunate, and thank you so much for being such lovely participants and guests, and your family now. Thank you.
Thank you. And tomorrow until the 16th, 14th, 15th, and 16th of November, we have the WHO Global Forum on Health Innovations, which we are hosting. There are some ministers from other countries, the director of WHO Digital Health and Innovation Portfolio in Geneva, participants from 40 countries arriving today. So we have another marathon of 3 days global forum happening. Some of you are staying back for that, others stay tuned. Thank you for visiting India. As I mentioned yesterday, nobody can, they must gain. Diwali family. We have everybody. So thank you very much. Stay healthy, stay safe, safe trip back home, and have a great life ahead. Thank you, everyone.
Apparently, one person can change the world.